So welcome back to NurseEdScholar. So today I'm going to talk about high alert medications in an NCLEX style form. Now I want you to remember, high alert medications are one of the fastest ways that students miss NCLEX questions. Not because, students don't really know the drug, um, but it's because you miss the risk of what happens if you give a high alert medication. So today I'm going to walk through NCLEX case studies for high alert medications so you'll know what to do as a nurse and what the NCLEX is expecting of you when you get those kind of questions on the NCLEX. High alert medications really kind of, it requires a different mindset. And in school, we always talk about, critical thinking, clinical judgment, because you really need to think before you give medications, especially high alert medications, because, sometimes we feel that we have to just keep moving and we need to do this faster and faster. But when you recognize the high alert medications, it's not about just giving the medicines. It's about, okay, thinking, is this the appropriate time? Is this the right dose? Should I give this dose of this medication? Because what would happen if I would give something and it's not the right time for it? And that's what you really have to think about. You don't want to just be automatic. You don't want to just see, the order that the provider has given you and you just do it. You want to make sure that, okay, when I give this medicine or any medicine, really, what is the worst thing that's going to occur? So you want to verify that order, because these medicines, you know, you may consider it a small mistake, but it can really cause big harm. Because anytime you see these medicines, these high alert medicines that we're going to talk about today, we're going to go over five of them. Your brain should automatically ask, what could go wrong here? What could go wrong if I give this medication? What can go wrong if I don't? And so that's what we're going to discuss. Because you need to remember, um, anytime you have a high alert medication, there is a big risk associated with it. So, like I said, you're going to need to slow down. You're going to need to verify, should I give this drug right now? Like the patient may be on the drug, but sometimes things can happen in the body that would cause it to where, right now is not the right time to give this particular drug. So you always want to think safety. So today we're going to talk about five drugs. We're going to talk about insulin. We're going to talk about heparin, opioids, not a particular opioids, just the class of opioids, digoxin, and potassium. So let's get started. Okay, so you have, a patient that's on heparin. Now, I want you to think about, it's not just about the lab value being high. So, you're looking at your labs, every time you perform any kind of intervention. So let's just say the doctor ordered heparin to give to your patient. And you have to look at the labs because you should know that heparin will affect the patient's PTT. And a rule I always use, I tell my students is that look at two T's and together they kind of look like an H. And so that's how you know that PTT goes with heparin. And you want to know that, with heparin, this is about the balance between, okay, you want to prevent the clots, but then you don't want to cause bleeding either. Remember that heparin works by inhibiting clotting factors. And that will increase bleeding time. And the PTT tells you how thin the blood is. So when that PTT becomes too elevated, there is a spontaneous risk of bleeding internally and externally, and in this case, the he had an elevated PTT, and then you noticed at the IV site, the patient's bleeding, so, what would you do? And so you would think, wait a minute, okay, what could be causing this? So remember, patients getting heparin, there's bleeding at the IV site, and this is not a minor finding. You shouldn't have bleeding around the site, especially if the patient is on heparin. So know that this is a clinical indication that the patient is already, experiencing the effects of anticoagulation or really over anticoagulation. So what would you do? You'd stop it. On the NCLEX, visible bleeding means that the problem is no longer theoretical. It is actively happening on your patient. So you want to stop the heparin infusion, because this will prevent continued over anticoagulation. So you're going to, more or less prevent bleeding, and you're going to keep monitoring those labs. You're going to keep monitoring the PTT. All righty. So let's move on to the next drug. Insulin. If you work on the floor, somebody every shift will probably have some kind of insulin. Okay. And remember, insulin lowers blood glucose, by moving the glucose from the bloodstream into the cells. And if you have too much insulin, those glucose levels will drop rapidly. And remember that the brain depends on the glucose to provide energy. Glucose is an energy source. So when the glucose level drops too low, the brain can't function. And it's going to lead to things like confusion, seizures, even coma in your patient. So that's why this is so important for you to monitor. All righty. So in this scenario, the patient's glucose is 110. Okay. So it's normal, right? So if you give insulin, you know, so that need may shift the patient from stable to potentially critical. So let's think of it. We have a patient, they have a glucose that's 110, right? So when you're thinking, you're like, okay, this is an order. Is my patient about to eat? Has my patient eaten? Is this, kind of think of the situation. Because sometimes what happens is that, you'll have a patient, you check their blood glucose, and the blood glucose is normal. Okay. But they're about to get a tray of food. All righty. So they may have an order of Humalog, okay, a fast-acting insulin. And then you're like, well, do I give it? Because typically what you're doing is the Humalog is to prevent the blood glucose spike from the food. But you have to think about your patient. Is your patient eating? If you look into the chart and everybody's saying, well, they're only eating about 25% of their breakfast, or they're really not eating that much, and then you've noticed that your patient is kind of nibbling, they're not really eating. So if you have an order of, let's just say, 10 units with meals, and you're looking, and that's why it's so important to look at your patient's chart and know your patient. Because if you give that 10 units, and let's just say that patient just haven't been feeling good and they don't eat, you are rapidly dropping that 110 blood glucose. Okay, and you're going to really put your patient at risk. So think about that. And that's why clinical judgment is so important. And so remember, with this high alert medicine, danger is often not what you see, but what will happen next if you act incorrectly. So here, like I said, you have a patient, they're not eating. So that's why you really need to know your patients. And they have 10 units of fast acting insulin, and their blood sugar is already 110. So what would you do? You hold it. It's okay to hold medications, because if you give it, you can't take it away. So you want to hold it, you want to verify the dose, because you want to prevent hypoglycemia. And so just wait. Wait till the patient eats. See how the patient, if the patient eats 75, 80% of their meal, then it'll be okay to give it. But if they're not eating or they're sleeping, you just hold the medicine until it's the right time. All right. Okay, so next is your opioids. We're not going to talk about a particular opioid, but your opioids, right? So remember that opioids bind to receptors in the brain stem, and they that control respirations. So opioids will decrease the body's natural drive to breathe. And a respiratory rate of 8, like in this case study, indicates a significant suppression of the respiratory system. And a decreased level of consciousness tells us that the central nervous system is already affected. So opioids can cause respiratory depression and it can decrease level of consciousness. So what would you do if the next time the patient is due for a an opioid medication? Sometimes patients are on routine medicine, okay, like MS Contin that may be given every 12 hours. So you're given that medicine and it's scheduled, but you go in and you assess your patient before giving it, and this is what you find. So what would you do? Well, you know, this no longer is a medication issue. This actually is an airway and a breathing issue. Your patient is getting MS Contin, which is a long-acting opioid for whatever reason, and you're going in and their respiratory rate is 8. They have a decreased level of consciousness. So what are you going to do? You're going to stimulate your patient. And, there's something that we call a sternal rub. You kind of take your knuckles and rub into the patient's sternum in the middle of their chest to try to wake them up. Then you prepare for naloxone, which will reverse the effects of the opioids. But one thing to remember with that is that it's not long acting. So you may give them the medicine, they may wake up and be alert, but you still have to go in because they can fall right back into that reduced respiratory rate and that decreased level of consciousness because those medications don't last very long. So you really have to make sure that you frequently observe your patient and then support airway. When you have a person that has a respiratory rate of 8, you may need to ambu bag them, especially if your stimulation and the naloxone isn't working as effectively as you could. So you're going to have to support that airway because, think about it on the NCLEX, um, once breathing is compromised, everything else becomes secondary. Breathing, airway, oxygen saturation, level of consciousness, it becomes, everything else becomes secondary. All right, now we're going to move on to digoxin. You know, sometimes students underestimate digoxin. And in this scenario, patient is on digoxin for, a cardiac reason. And before administering this medication, you're supposed to assess the patient's apical pulse. And on this patient, it's 52 beats per minute. Now, what would you do? What would you do? What do you think you would do? Well, let's see. First, you need to recognize that digoxin causes low heart rate. So it causes bradycardia. And you're supposed to hold digoxin if the heart rate is less than 60. All righty. Then you're going to kind of say, okay, well, I know that digoxin lowers the heart rate. So what's going on? Well, digoxin works by slowing the heart rate and increasing cardiac contractility. And the risk for digoxin is that you'll have worsening bradycardia that'll lead to decreased cardiac output if you give the patient too much digoxin. So they may have digoxin toxicity. You just given too much. And right now, you already know that the patient's heart rate is 52. You give them more, it will decrease that heart rate even further. You need to remember that digoxin has a narrow therapeutic range. And this means that even in small increases in the drug level, it can lead to toxicity. And one of the earliest signs and most critical signs of digoxin toxicity is bradycardia. And so administering the digoxin when the heart rate is already low, like I said a few seconds ago, it can push the patient into a deadly dysrhythmia. So with patients with digoxin, you always want to check the pulse first, the apical pulse, before giving digoxin. Because if you just walk in there and say, oh, and you look at the vital signs and you don't know if those vital signs were correct, you don't know how long, I mean, they may put a time in there, but you don't know when the actual time was. And if you just give that digoxin blindly, you could really cause harm to your patient. All righty. And lastly, potassium. Potassium, boy, potassium can definitely do some damage. This is one of the most dangerous high alert medications. So in this case study, the provider has ordered IV potassium for your patient because the patient has low potassium levels for whatever reason. And the nurse begins to prepare to give potassium IV push. Is that an appropriate way to administer potassium? Would you give it IV push? Okay, let's think about it. First, you need to recognize that the potassium is ordered and the route is IV push. So you're like, IV push. What does potassium do? It affects cardiac conduction. And the biggest risk is fatal cardiac dysrhythmias. So if you give that patient IV push potassium, you will more than likely kill your patient, cause them to go into cardiac arrest. So the most appropriate action here is to stop and question the order because you're like, I'm not supposed to give this IV push because potassium must never, ever, ever be given IV push. The rate of administration, that fast administration with the push can cause immediate and severe cardiac dysrhythmias, including, like I said, cardiac arrest. So potassium must always be diluted and infused using a controlled infusion pump. And a lot of times you'll see with potassium, it has guardrails on it to make sure that it doesn't run too quickly. And you need to use your guardrail drugs. They will really, the guardrail functions on your IV pump because they can really save you and protect your patient. So remember, on the NCLEX, IV push is always wrong. Okay. One thing about high alert medications, you really need to notice a pattern. I want you to realize that it's not all about memorizing drugs. It's about recognizing the risk that is associated with those drugs and to know that you need to slow down and you need to verify the orders and you need to perform the safest action because you always put your patient first. You always protect your patient. And sometimes you may not know what to do, but you have to realize that, if you look in your drug book and you're still uncertain, go to a more seasoned nurse. But you always should know the effects of the medications that you're giving and what will happen if you give it. Because you want to remember the NCLEX is not asking you, what does the drug do? It's asking you, you know, when something isn't right. It's asking you when, should I give this medicine? Like I said earlier in the beginning of this video, is this the right time to give this medication? Because the medication can be given, but is this the right time clinically right now? Can you give this medication? And that's where that clinical judgment comes in. So I really hope this was helpful. I really thank you for watching Nurse Ed Scholar. I'm really trying to create something where you're not really memorizing, but you're really understanding what you're doing and what you will be doing as a nurse. So if you've liked this video, please like, please subscribe, turn on notifications, and I just, hope that you continue studying and that you pursue your goal as being a nurse. And I guess, until next time, happy studying from Nurse Ed Scholar.